interesting session on decoding dilemmas in clinical practice. To make this session even more interesting and to moderate this session, we have Dr. Rishi Mohan, who is the Director and Senior Consultant Ophthalmologist Surgeon at MMI Tech Institute of Ophthalmology, New Delhi. As a panelist for this session, we have Dr. Vasumati Vedantam, who is a Medical Director, VR Surgeon, Pediatric Retina Specialist at Chennai. We also have Dr. Shirish Nelvigi, who is a Director and Glaucoma Specialist at Nelvigi Eye Institute, Bangalore. And from Cornea side, we have Dr. Paras Mehta, who is a Medical Director and Cornea Consultant at Sameep Eye Hospital, Baroda. So please give a warm welcome to all of our moderator and the panelists. Over to you, sir.
Well, thank you very much, and good afternoon, everyone. It's just past the middle of the day. So I think we have an interesting session, and I thank Allergan as well as the AIOS for giving us this opportunity to sit here and deliberate on these dilemmas. And we have some very, very interesting eye-opening and cases that we're going to look at. And we're going to do this case-based, and I'm going to have my esteemed panelists give us their thoughts on the case once it's presented. And I would want them at the end to summarize with a one-line take-home from whatever we learn from that case, so that we can derive some benefit from this session. So I think the panelists have been introduced very briefly, and we're going to go on keeping time in mind. And we're going to start with, I think it's Dr. Sheetal presenting first. She's presenting her cases first. Sheetal, please come in and tell us about your patients that you'd want us to discuss. So we're starting, the session is going to be in 3 parts. We're going to be doing some glaucoma patients, some cornea patients, and some retina patients. And then we're going to have our esteemed panelists give us their inputs and insights on how best to manage these. Go ahead, Dr. Sheetal.
Okay, thank you, Dr. Rishi. Good afternoon, everyone. I will be talking about some glaucoma cases. Now, whenever we deal with patients of glaucoma, we are usually faced with a lot of questions like, do we need to do investigations in this patient? Should we start medication? Should we go for surgery? Which medications to use? So there are a lot of questions that we need to solve when we are talking about glaucoma patients. So I have taken a few cases that we see, the cases that we see day in, day out in our glaucoma OPDs. So let's start with the first case. Now, this is a 45-year-old male. He was referred to us because his intraocular pressure was recorded to be high on a routine checkup. When we saw him on applanation tonometry, his intraocular pressure was 22 in the right eye, 24 in the left eye. The pachymetry was normal, 530 microns in the right eye, 535 in the left eye. And when we looked at his discs, this is what his discs looked like. The cup disc ratio was around 0.6 with a healthy neuroretinal rim in both the eyes. We did a gonioscopy first for him, and his angles were found to be open. Then we asked the patient to come for a diurnal variation monitoring. So we normally do a day diurnal since we don't have the facility of nighttime diurnal variation. So we took multiple readings at different times of the day, and we found that his intraocular pressure was somewhere in the range of 21 to 24 in the right eye, and in the range of 20 to 22 in the left eye. We asked the patient to go for a perimetry and a OCT testing, and this is what his perimetries looked like. There was some scattered defects in the bioacute region, and on the OCT there was a superior wedge defect that we could see in the right eye. Now, since this was his first perimetry and we have to allow for a learning curve in all glaucoma patients, we labeled this patient to be a ocular hypertensive. So the question that we were faced with at this point, and I think in ocular hypertension that we all have to answer, is do we treat or do we not treat? So what are the risk factors? Like, how would you decide whether we want to treat this patient or we don't want to treat this patient? So based on the intraocular pressure, broadly we can classify ocular hypertension as being a low risk, a moderate risk, or a high risk. Now, once we have decided this based on the intraocular pressure, there are multiple other factors that we have to take into consideration. Of course, the age of the patient, Very importantly, the family history of the patient. If a patient having a family history of glaucoma, we would definitely, even in low risk or moderate risk cases, we might like to treat that patient. Another important factor is the central corneal thickness. Now, central corneal thickness, one thing that I would like to say, we normally don't use the correction factors when it comes to central corneal thickness, because there is no direct linear correlation of a pachymetry with the intraocular pressure. Besides, central corneal thickness is not just about making corrections in the intraocular pressure. It is also about how it's a reflection on the physical and structural factors which affect development of glaucoma also. So what we normally do is that we just keep that in mind when we are deciding our further course of management. So a patient having a low pachymetry, we would be more likely to treat. A person with high pachymetry with ocular hypertension, we would be less inclined to treat. There are multiple other factors also, such as diabetics. Myopia is one of the known causes where we know that it has an effect on development on glaucoma. A larger cup to disc ratio, and very, very importantly, the disc hemorrhages. In the presence of disc hemorrhage, we would definitely like to treat these patients. Disc hemorrhages are known to a very known association with progression and development of glaucomas. So based on the kind of risk, our treatment pattern would be like in low to moderate risk cases, we would maybe observe either 6 monthly or annually, depending on the risk profile. Sometimes in these cases, if the patients are very apprehensive, or we know that these patients are unlikely to come for a follow-up or examination, then we may start these patients on medications also. And of course, in high-risk ocular hypertension, we would initiate treatment usually with a single drug, and we would aim for around a 15 to 20% reduction of intraocular pressure. So coming back to our case, we saw that intraocular pressure and the OCT, these were the two suspicious factors that we had found. So we counseled this patient, we gave him the option of remaining either under close observation annually or maybe starting a single drug prophylactically. So the patient chose to remain under observation, and he has been undergoing annual checkup since 2016. We saw him last year. This is what his fields and his OCT looked like. So the fields were almost relatively normal after 5 years, and the OCT was also normal. So the point here being that treating and diagnosing glaucoma early is of course important, but it is also important to know when we should not treat a patient of glaucoma. Now going on to the second case that we have. So this was a 60-year-old female. She was a known case of open angle glaucoma since the last 5 years. When we saw her, she was using latanoprost eye drops HS in both the eyes. Her intraocular pressure was 19 in the right eye, 24 in the left eye. Pachymetry was relatively normal, 507 micron in the right eye, 512 in the left eye. On gonioscopy, the angles were open. This is what her discs looked like. In the right eye, the cup to disc ratio was around 0.6. In the left eye, it was around 0.8. The field showed an inferior nasal step in the right eye, and there was partial biacuate scotoma in the left eye. On OCT, we could see that there were Rnfl changes more in the left eye as compared to the right eye. So our diagnosis here was that the patient is a case of primary open angle glaucoma. Now the next question was, what is the plan of action next? So the first thing that we have to do is we have to decide what is our target intraocular pressure. So what is the pressure that we need to bring this patient down to? So a general guideline can be something like this, that in early glaucomas, we would like the pressure to be below 18, in moderate below 15, and in advanced glaucoma, we want to set it to below 12. Now this is the starting point. There are other factors which would definitely affect our target intraocular pressure. Mainly the speed of progression of the disease, the life expectancy of the patient. Now this is important. So we would not treat a 80-year-old patient the same way that you would treat a 30-year-old patient. You don't want to aggressively treat a 80-year-old patient and decrease his quality of life just to bring down the pressures by a few millimeters if we know that the chances of him losing vision throughout his lifetime are less. Vice versa, in a younger patient, you would definitely want to treat much more aggressively. Central corneal thickness, as I previously said, it would definitely have an effect on our target intraocular pressure. Pseudoexfoliation has been known to be one of the factors in which progression of glaucoma happens really fast. Disc hemorrhages and multiple systemic diseases that we have seen. So based on these factors, we are going to change our target intraocular pressure. Now, in this patient, we diagnosed to have early to moderate open angle glaucoma in the right eye and advanced open angle glaucoma in the left eye. So our target intraocular pressure that we set was around less than 15 for the right eye and less than 12 for the left eye. So we advised this patient to shift to Ganfort, which was a combination of bimetoprost and timolol in both the eyes, and brimonidine and brinzolamide combination in the left eye. Fortunately, the patient reached the target intraocular pressure, and we were able to keep her under control this way. But if our target intraocular pressure would not have been reached, our next course of action would have been a trabeculectomy. So in which case would we have advised a trabeculectomy for this patient? So if the patient, the intraocular pressure was not controlled on maximum tolerable medical therapy, or we are seeing progression in spite of maximal medications, or the patient is not tolerating or having some sort of allergic reaction to the medication, or is not compliant with the medication, not putting the medications regularly. So in either of these cases, we would maybe have advised the patient for a surgery. So to conclude, I would like to say that we have seen that glaucoma management is not exactly a straightforward process. A detailed and complete examination, which is gonioscopy, disc evaluation, and perimetry, all of these are very important. And specifically, I cannot emphasize enough the importance of gonioscopy in glaucoma patients. We see a lot of patients who have been treated for years without having undergone gonioscopy. So that is one very important test that we need to take into account. And the second thing is perimetry always comes first. You do not do a OCT or imaging without having done a perimetry. So a perimetry also has to be done in all cases of glaucoma. And we should always treat the patient as a whole. Thank you.
Thank you, Dr. Sheetal. I think very nice two cases which opens up a whole area of discussion, and I'm going to request Dr. Sirish to give us some no, I think since the cases may be slightly different, we'll wait for let's try and see if we can at least address a few of the factors that she has brought up on ocular hypertension versus mild early glaucomas.
Can you just put the previous case, please? The first one. Let us discuss that.
Ocular hypertension.
Thank you, Dr. Sheetal. Pretty interesting cases, and moreover, they are very common day-to-day cases. What Dr. Sheetal has shown, that's like far more important. If we keep talking about very rare cases, I think we don't end up anywhere because they are exceptions. We need these common cases to take us forward. So I just want to pick up and point to a few very crucial things, because most of the good points already Dr. Sheetal has said. So when we are trying to identify whether it's a case of glaucoma or not, our role is more like an investigator. We have to put everything together, lot of factors together to bring in a diagnosis. Just, commonly taking into account just the intraocular pressure is high, so this is glaucoma. We should avoid such a temptation and jump into the diagnosis and avoid the temptation to put the patient on lifelong medications. That's what happens in majority of such situations. Now, here there are a few things which actually, according to me, are clear pointers that this is not glaucoma. For example, to start with, if you see the disc photograph, the previous one, please. So the disc photograph shows, even though the cup is large, even though the cup is deep, you can see the kind of symmetry that you are seeing between the two cups. It's like the two hands are matching, The cups are matching. There is a very neat rim, very nice NRR, good RNFL there, what you can see. So in such situations, again, please avoid the temptation to jump into a diagnosis of glaucoma. This is point number one. So this is your first warning signal. Don't jump into glaucoma. When it is symmetrical, no, don't do that. In fact, you have to do the investigations more as a matter of completion of the investigations, just to confirm it that it is not glaucoma, not to confirm in the glaucoma, it is to confirm out the glaucoma. And then coming to the OCT, again, a lot of people will have temptation, if you see there, the RNFL deviation map, the second map, if you see that wedge-shaped RNFL loss there. Again, that gives you a temptation of making a diagnosis of glaucoma just based on that. This is called a red disease, where, just the all these investigative modalities with that red mark, you end up putting the diagnosis of glaucoma. Again, avoid it. Here, why is it showing red? We have to know that. See, the RNFL actually is pretty healthy. There is no problem with the RNFL. We have a physiological variation of RNFL which is called as Bifid Rnfl. It's a very common thing. It's not a rare thing. The the RNFL will have that bifid pattern, and whenever the bifid pattern is there, the in-between area between this bifid RNFL area definitely shows up that wedge-shaped RNFL loss. It is for us to understand that this is a physiological RNFL variation and not a RNFL loss there. How do you confirm it? It's very simple. See, now I'm sure you are convinced about, like, let's say the left eye, you are very, very convinced that, okay, see, this is a healthy RNFL. Now, if that is a RNFL loss, you should be seeing a correlating visual field defect in that area on the right eye there, here. So, it is not exactly correlating. In fact, what I would say, it is even those two black spots, they are pretty scattered about. They are not in one single concentrated area. RNFL loss of that magnitude, if it's actually a RNFL loss, will show up a much bigger defect there, point number one. Second, again, avoid the temptation of just putting your diagnosis just based on one visual field testing. In fact, when you diagnose the patient and when you have done the first visual field, make sure at least you do 1, 2, 3 visual fields till you are sure that you have got a good baseline. It is a subjective test, it has got a learning curve. Never skip that fact in your mind. You can get away with doing, obviously, with one RNFL measurement because it's an objective one, but same is not the case with visual fields. So probably, most likely, if you repeat the visual fields 2, 3 times, you may not even see those two black spots that you're seeing there. So now your diagnosis is already shattered, you know, if you're making a case of glaucoma, it's already shattered. The physiological loss there, which you confused it for actual RNFL loss, the symmetry of the disc, actually, all these things when you put together, and don't jump at the intraocular pressure. This probably, I think you put it pretty well. We'll move on to the next case if you can. So I'm just trying to show you how you have to go step by step. Don't get carried away by one factor, just the intraocular pressure. This is what the whole point. In fact, that is the strong take-home message which I would want to give from Dr. Sheetal's first case, my personal message rather. This is the second case, yeah. So this was an advanced case of primary open angle glaucoma. Here I think the situation was quite clear cut. Here you have to make up what is your target IOP and then go ahead treating it. Again, a small word of caution here. When you have such an advanced loss, you know, when the OCT is there, I am sure like quite a few of you would have heard about the floor effect. Yes, yeah, so when there is a certain amount of a RNFL defect which already happens, there is no point in keeping on depending upon the OCT. In fact, if you have a, if the patient is not affordable or something, I would rather say, you know, you can even skip the OCT. It's not even necessary. It's not going to give us any added information. You have to, in such situations, you have to keep basing all your information on all your diagnosis and treatment plans on the visual fields. Where does the visual field role come into play in such a scenario? What the second case says, it's an established POAG. Visual fields is here important in not in making the diagnosis, you already have it. It's important in noting the progression. This is the message I want you to take from the second case what Dr. Sheetal is talking to you about. So in such situations, again, one field is not enough. Okay, if you have done one, in fact, such an advanced case where the fixation is already getting threatened, for example, in that eye, so left eye, so if the fixation is getting threatened, do the visual fields every 6 months. You have to step up your visual fields. Don't let lose the visual fields. It's extremely crucial here. That is what is going to tell you whether the patient is progressing or not. Only then you will be able to hang on to the glaucoma damage from letting it go worse and further and save the patient's vision. So these are the 2 points I wanted to make from your side. Thank you for such a nice, wonderful presentation.
Thank you, Dr.
Thank you, Dr. Sheetal. Thanks very much, and thanks, Suresh, for those valuable comments. I'll request Dr. Vineet to set up his slides and his introduction. So just as a concluding comment and to give you and reiterate the concluding remarks and summary that Dr. Suresh said. One is, Sheetal mentioned about the central corneal thickness and how it can actually not be directly correlated. We often don't use correction factors. However, a corrected factor employed routinely in your practice in intraocular pressure measurement would still be a good thing. It can't be worse than not using it. So at least that is one thing. The second is, corneal thickness really say the post-refractive patient. Now you're not going to get accurate IOPs on these patients. So how are you going to use that as a benchmark? So what you need to look at is actually the biomechanics. And it's important that you look at biomechanics and use biomechanically adjusted IOPs rather than corneal thickness algorithm-based adjusted IOPs. That will give you a much better idea of the control on this. So, and then of course the two comments that Dr. Suresh gave. One is don't take the IOP as the only factor and get carried away. You see a patient with a 28 pressure and you put him on treatment. It may not be. He may just be high risk, but he may not actually be glaucomatous. And that the visual field is important to monitor the progression of these patients, especially if the central field is threatened. Isn't that?
Repeat the fields. Keep repeating them.
Okay, so let's move on. Vineet.
So thank you, sir. And my talk would be on the decoding dilemmas in glaucoma. We would talk about the maths of progressing patients. So when we come to the glaucoma, actually there is no maths. 1 plus 1 sometimes goes to 2, 1 plus 1 sometimes goes to 2.5, 1 plus 1 can be 1 also. But clinically speaking, what are the things which should be in our mind when we talk about the glaucoma management? So first factor would be staging of the disease. Is it an early, moderate or severe? Always basically stage the disease according to your visual fields. Not, as sir has told us, OCT is not there for as a staging modality. Then always do a gonioscopy. It has to be classified whether it is an open angle or a closed angle glaucoma. Always see what is progression, as sir has told me, made my life much better, that always see whether the patient is progressing or not on the basis of visual fields, whether the patient is a slow or fast progressor, whether you have to start the treatment, as we have discussed in the last case in OHT, whether you have to start the treatment or whether you have to just follow up. Then when you start the treatment, whether it should be a monotherapy, if there should be, the patient is not having a controlled IOP on the monotherapy, target IOP is not achieved, whether you want to add on or do you want to change or you want to go for a combination therapy. Switching, whether you, if it is not basically controlled on your maximum medical therapy, would you like to go for a surgery or new type of lasers? And what should be your follow-up? It should be follow-up should be for the effect of therapy. Follow-up, intense follow-up should be there in the advanced cases, and what should be your regular follow-up? If a patient of OHT is there, whether you would like to follow up every 3 months, 6 months or 1 year. Okay, so as we know that the rate of visual field progression can basically vary. If the patient is a patient who is having a severe functional impairment, if there is a young patient with advanced glaucoma, we know that we do not have much time. We have to basically step our treatment. If the patient is a slow progressor diagnosed as a early glaucoma at 80 years of age, would you like to go for an intensive treatment or just a moderate treatment? Okay, so this is not a complete slide, but should be in your mind when you start your management. If the patient is having a early glaucoma, you start the patient on your PG analog. If the patient is moderate glaucoma, not controlled on your PG analog, would you like to go for a PG analog plus beta blocker, or would you like to go for a combination therapy twice a day, or would you like to go for any other therapy? If the patient is severe or advanced glaucoma, would you like to go for a combination of combined therapy, or would you like to go for the surgery straight away? Okay, so everything you have to decide individually. I start my slides with this. There is actually no maths in glaucoma. 1 plus 1 can be anything. Okay. So the first case is 55-year-old gentleman came to the OPD, nasal step on visual fields, everything is okay, open angles, cup disc ratio was 0.8 with inferior thinning, with Rnfl thinning, corrected IOP was 23, and what is our target IOP? So we know now this patient is a patient of early glaucoma. So the target IOP here should be less than 19. Okay, so whenever you basically make a target IOP, you have to have something in your mind. You should be knowing whether this patient is an early glaucoma, advanced glaucoma, moderate glaucoma, and what is the baseline IOP in this patient, and what is the need of the patient. Okay, so scenario 1 is, you know that this is not an angle closure. You started the patient on PG analog, and you follow up the patient after 4 to 6 weeks. Now there can be 2 scenarios. So first scenario is that what you want in your clinics, 23 goes to 18. You continue the treatment, you do a 3-monthly and 6-monthly follow-up, visual fields are repeated. In initial 2 years, everything is fine, and you tell the patient, now it is controlled. Please, please, please be on regular follow-up, at least 6 monthly IOP checkup, and once in a year visual fields are must. Okay, so as EJ has also told us, the first line of therapy should be the PG analogs. And because, why the PG analogs? Because we know that these are the ones which have the highest IOP reduction and the safest to the patient also. Okay, so even if your target IOP is reached, one thing that I want to give a message is, please, please, please tell the patient that still your regular follow-up is so important. Okay, so scenario 2, which I do not want, 23 goes to 20, so we have a suboptimal IOP reduction, which the patient says, okay sir, I am okay, but 23, you know that even 20 is on a bit of higher side. So would you like to go for a combination therapy right now, or would you like to change your therapy? So in this case, I changed to bimatoprost, but definitely I could have gone for a combination therapy. I tried my luck. I thought that, okay, I changed the patient from letanoprost to bimatoprost. 23 goes to 18. Now the follow-up 3 monthly, I did the visual field. Visual fields were stable, and the 6 monthly IOP monitoring was there. I did a DV for this patient also, Rnfl imaging, everything is fine. I'm so relieved. Okay, so what I could have done different in this patient, I could have started the patient on bimatoprost as the initial therapy. Now, the studies also see that the patients who are having started the bimatoprost as the first line of therapy initially have the highest amount of IOP reduction, and even in those patients where you change the therapy from one PG analog to another PG analog, you may still have some more reduction of IOP, but do not expect more than 10-15% more. It may be 1 or 2 millimeter maximum that may be there with the change of the PG analog. Now I come to my second case, which was a more difficult to me. 65-year-old gentleman, hypertensive with uncontrolled blood sugar. Patient came in the COVID era. There were a lot of cases. The biarcuate defect on visual fields, 0.9 cupping, bipolar thinning, mild NPDR, and the patient was only on one drug, timolol, and the IOP was 21. And as ma'am has told us in previous slide also, that in this patient you want to have as less IOP as possible. I want to be in less than 13 millimeter of mercury in this patient. So gonioscopy is done. So one point is very, very important, that whenever you start this treatment, whether this patient is from treatment from other side, please repeat gonioscopy again and again, because this angle closure, or sometimes zipper-like or synechial angle closure, if it increases and you do not basically get to know that patient is an angle closure patient, and you increase the therapy again and again, finally you are going to basically get problems in the patient. So started the patient on maximum therapy. When you want the maximum IOP reduction, you want a Virendra Sehwag in T20 mode. So you want something that, okay, now I do not have any option. Next option is I have to go for a surgery. Before going for surgery, I want my best player to basically open the innings. You start the patient on bimatoprost plus timolol combination with a CAI, a carbonic anhydrase inhibitor with a alpha agonist. Okay, so scenario 1 is something which I want. 24 goes to 12. I continue the treatment. 3 monthly, 6 monthly follow-up was done. There was one slide regarding the visual fields. I think that is missing, sir. I have put the visual fields also of that patient with the, I think, just a minute, if I have the, okay, I think that is basically, okay, so scenario 1 is 24 goes to 12. I continue the treatment. 3 monthly, 6 monthly follow-up was done. Visual field, very, very important, is even when you have a IOP reduction, which you want, and still you do not know, because patient comes to you in the OPD only in the morning or in the afternoon, there may be a spike in the IOP in the night. So you want a diurnal variation, and please, 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 advanced glaucoma needs visual field, as sir has discussed, very, very frequently. If possible, do it 3 monthly, if not, go for 6 monthly. And I would also say that whenever you do a visual field analysis, please include it a 10-2 or a 24-2C also in, because you want to see what is your central vision in this patient. So always I make it a point, instead of going for a OCT in advanced cases, I basically do a stereoscopic fundus photograph and I draw it where I am seeing the notching. So unfortunately that slide was missing where I have put the drawing also. So scenario 2 is 21 goes to 18 millimeter of mercury. Even after maximum medication, my option here is only trabeculectomy, nothing else. But patient is on uncontrolled blood sugar, NPDR, and patient and you cannot do the surgery. So what is the option right now? You tell the patient, yes, we have something more, we can go for a micropulse therapy. I would definitely not recommend micropulse laser as an alternative to the trabeculectomy, but something which can be some time saving for me, because in my hands also I have seen the 3 months, 6 months follow-up. The patient may returning to the baseline IOPs after a month or 2 months or 3 months. So you have to tell that, yes, I am doing a micropulse therapy. It may work, it may not be work. Till then, please control your blood sugar. So in this case, fortunately, IOP reduced to 14 millimeter, and the patient was told that you need a serial follow-up. And I write, my session before that was on the medico-legal aspects. So I write in clear that still your target IOP is not reached, and you need to go for an intensive control of blood sugar. So thank you. Last slide is, you need a more aggressive treatment in those patients who have young age, advanced glaucoma, where the life expectancy is long and the risk factors are more. Thank you, sir.
Yeah. Thanks very much, Vineet. I'm going to request Dr. Suresh to just give us the take-homes on this one, because there's not really much time to go on, and I'd request Dr. Monica to set up her slides. Vineet, come and join us here.
Thanks, Vineet, for nicely concluding the whole gamut of glaucoma there and its treatment in a very brief way. I'll summarize both the presentations with some important point. See, planning to treat glaucoma is something like fiscal planning. You all keep hearing about what's happening in Sri Lanka, Pakistan. See, it's all to different reasons. The way Sri Lanka managed was due to pandemic, they went down. But then Pakistan, if you see, it's a long-term loss of planning which is happening, you know, since many, many years or decades. Similarly, when you see a glaucoma patient, he's, say, for example, 55-year-old 0.8 cup with about, say, 25 millimeter mercury. What do you see the first thing? The first thing you see is 55-year-old. So he has another 45 years approximately, or 50 years to live. So he is different from a person who is, say, 80-year-old or 70-year-old, where you have to plan his vision only for 10-15 years. So that's the most important thing. So now this is where the example of fiscal planning comes in. At the 50-year-old patient, if you don't start planning your work right from the beginning very, very tightly, you are going to lose his vision. Just like the economy is going down, in about 10 years, you are nowhere and you can't get it back. So one very, very important point out of those whole thing what Dr. Vineet said, make it like a fiscal planning, plan your treatment right at the beginning, keep the age of patient in mind, which is extremely crucial. Plan how many years of vision you need to give to that patient and how many years he needs to retain his vision. Accordingly, start the treatment, accordingly plan your treatment. So for that, you have glaucoma progression analysis, which is available in the visual fields, which will also approximately give you how many life years of sight years he has, but you can do it even clinically also. Okay? Thank you so much, Dr. Vineet.
Thanks very much. I'm going to go on to the next section, which is cornea. And with our first presentation by Dr. Monica Jethani, she's going to tell us about some special cases that she has seen. Go ahead, Dr. Monica.
So, very good afternoon to our respected panelists. I'll be talking about one severe case of dry eye, and I'll be discussing role of hyperosmolarity and how quarantine has led to increase in progression of dry eye disease. So basically we had this one patient, a female aged 50 years with symptoms of redness, foreign body sensation, blurred vision in both the eyes and burning sensation. So the symptoms were there since 5 years, but they worsened in last 2 years. Comorbidities were dry mouth and nose. She was initially on artificial tears, unpreserved, but the effect was very mild relief. So we did some diagnostic tests in both eyes. So there was conjunctival hyperemia, punctate keratitis. T-BIRD was hardly 1 second, very high fluorescence staining +4. On diagnostic results, we found anti-SSA positive. And there was conjunctival interpalpebral Leishman green staining +4. Schirmer test without anesthesia, that is Schirmer 1, was just 1 mm in 5 minutes. So the diagnosis came to be primary Sjogren syndrome. So how we treated the patient was with non-preserved artificial tears, 6 times, increased to 6 times in a day. Lotepredniolol, we started the patient on Restasis, that is 1 drop in each eye for two times in a day for 1 year, omega-3 fatty acid and hydroxychloroquine. So the patient was followed up after 1 year, and the symptoms were much relieved. Schirmer increased a little bit. Conjunctival staining was less, and the patient was again advised to continue rhestasis and artificial tears. So basically what I want to say is dry eye disease affects the quality of life. It reduces your quality of vision quite a lot, leads to psychological issues like anxiety and depression. And India is believed to be on threshold of dry eye by 2030. There's a beautiful article by Nepali et al. On how quarantine has led to increase in progression of dry eye. So basically dry eye has increased by approximately 50% in the quarantine period. So reasons were basically more indoor activities, lack of sleep, higher stress levels, increased pollution, and so on, increased screen time, and so on. So the newer onset of causes of dry eye were digital eye strain, mask-induced dry eye, sanitizer-associated dry eye, and vitamin D-induced deficiency dry eye. So basically in digital eye strain, there was low blinking, and which led to high tear evaporation, ill-fitted face mask, because all of us were advised to wear face mask, and which really increased the incidence of dry eye because there was dispersal of air around the eyes. And use of sanitizer led to ocular allergy-like symptoms, leading to inflammation and increasing the hyperosmolarity in the tears. And also vitamin D deficiency was one of the major factors. So what is the role of hyperosmolarity? When a normal cell is exposed to hypertonic environment, the cell gets dehydrated, there is loss of water, and if there is a normal natural regulatory mechanism which happens, for the short duration of time, there is uptake of inorganic solutes, and this cell again swells up. But under stress-related conditions, the cell is again damaged and there is apoptosis. So if there is, here comes the role of osmoprotectants. If there are osmoprotectants, the cell volume is restored. So the key mechanism of dry eye is a vicious cycle which starts with tear film instability leading to hyperosmolarity, which in turn causes cell damage, apoptosis, nerve stimulation, leading to inflammation, MMP activation, goblet cell loss, and the cycle goes on. So basically the tests to be done are TBET. In this, if it is less than 5, it is strongly suggestive of severe dry eye. Ocular surface staining. Schirmer test less than 7 is suggestive of severe dry eye. MMP 9 for inflammatory markers. And so standard therapy for dry eye is, if it's a mild case, start with lubricating, but moderate to severe dry eye, we need to treat the inflammation part. So anti-inflammatory therapies which are available are cyclosporin, corticosteroids, oral tetracyclines and macrolides, omega-3 fatty acids, serums, cytokine inhibitors, and TNF-alpha, along with artificial tears, secretagogues, and in last case we can use punctal occlusions also. So a slide about cyclosporin A, how does it act is, it inhibits the T cell activation, inhibits leukocyte migration, and protects epithelial cells from apoptosis. So to summarize, inflammation is one of the 4 key mechanisms of dry eye. Stimulation of inflammatory mediators result in a positive feedback loop. Examination of patient's face, slit lamp examination, ocular surface staining, and MMP9 levels are important for the diagnosis of inflammation. There's wealth of therapies for treating inflammation, including artificial tears, cytokine inhibitors, serum, corticosteroids, and cyclosporin A. Cyclosporin A is effective at reducing the signs and symptoms of dry eye disease with no severe adverse events, and patient compliance can be improved with primary diagnosis of dry eye and patient education. So thank you so much for the patient listening.
Dr. Paras, can we have your inputs on this case?
Yeah, in fact, I mean, it was a very nice case, Monica. And here I would like to say that, I mean, COVID time has really given us, different phases of, life, and one of them is, facing dry eye, especially in her case. Like, this case was not usual. Here there was an involvement of the systemic condition. So whenever as a comprehensive ophthalmologist you are seeing patients of dry eye, apart from symptoms and all, it is also important that if the symptoms are persistent, with the regular medical management, you must, and this was for 5 years, right? Yes. If I recall correctly. Yes. So that means you have to look into the other aspects of dry eye as well. Primarily, we all know that you would like to clinically, differentiate between aqueous deficient or, evaporative dry eye, or is it a combination of both? You have looked into all these things earlier when you are seeing these patients in your clinic, and still, despite the management, the patient keeps on progressing, then you would like to look into the systemic aspect of it, that we must be missing, some other aspects, and then you have to look at, primary or secondary dry eye. And here it turned out to be a Sjogren syndrome. So it is very common in female, gender, but it is not uncommon in male gender as well. So even you have to look at that, because many a times we think that she is a female, let us investigate her further. But even male gender, we do have patients with SS, and then they are treated, they do very well. So that is one part. The other part which I liked is, instability of the tear film would definitely lead to inflammation onto the ocular surface. And if you don't treat this inflammation, probably your patient's symptoms and signs would not resolve very well. So it's important to treat them either with, short course of topical steroids, or if you want to treat them for a longer term, maybe cyclosporine eye drops, and especially the ones which are, good on the surface, like which are surface friendly. At the same time, I would also like to point one more point that, which are the cases where you would like to start cyclosporine. Because very recently there was a very nice paper from LV Prasad Eye Institute wherein you can look at, the tear gland and check with the fluorescent stain whether they are functional. Yes. If they are functional, yes, then if you use, cyclosporine A eye drops, then it is, going to work. If they are non-functional, if you don't see any secretion there is no point in, putting these patients on long-term cyclosporine, because you are not going to use it only for a month or two. You're going to use it for maybe 6 months or a year and see how the response is. So these are the cases wherein you would like to add cyclosporine, and especially the steroids, topical steroids, use it for a very short term till the ocular surface is stabilized and the inflammation goes down. Then only your, topical lubricants and other agents are going to work. And also take care of, meibomian gland disease, especially, by giving them, night ointment, or, they are very classical, signs by which you can, differentiate between these, dry eyes, like, which is known as differential staining. And of course, we can go on with this, but you have to look at those things and understand that which cases you are dealing with and how you are going to deal with that. And then the results would be wonderful. Thank you, I guess. Thank you, Monica.
Thanks very much, Dr. Paras and Dr. Monica, for a very nice discussion on dry eye. And I think, Dr. Natasha, can we have your slides, and while I just sum up. So basically what we learned from this is that if there is a persistent dry eye not responding to therapy, you must look for systemic factors. That's one thing that we can take home. Don't just assume it's a local eye disease, it may be something else. Second is, when you actually get into the therapy, the strategy will have to involve an anti-inflammatory approach as well. Especially if it's a moderate or a severe dry eye, you must do an anti-inflammatory approach. And there we've already talked about cyclosporine, and we talked about the initiation of the therapy for the short term with a low intensity steroid. And there are other anti-inflammatories also that are available. There's chloroquine, there's tacrolimus as well that can be used in these patients. And the other important thing which I think you highlighted was the fact that you were using non-preserved tears, and I think that's very important. And I have glaucoma colleagues here who would now also agree on the importance of trying to use non-preserved tears, non-preserved formulations for their ocular surface, because they are also long-term treatments and they will eventually lead to a problem with the ocular surface. Dr. Natasha?
Well, thank you. Just taking a leaf from what Dr. Paras said, we're talking of inflammation. So my 2 cents on inflammation and the case that I have here is primarily based on that. And the cases are absolutely elementary. There's no hi-fi signs in this, just absolutely elementary cases. So this is a patient 23-year-old male who came to me for refractive error correction. I was very happy that everything is, his refraction is stable. This was his topography. Just looking at the topography, I felt just because of the cylindrical correction that he had, I prefer to do a LASIK and not a smile on him. So we did a femto LASIK for him. He was quite excited to lose his glasses, but so my optometrist came to me on first day post-op saying that, ma'am, his vision is not improving to 612. It's not 6.6, it's 6.12, and he's complaining of slight glare. The pressures are okay, so I said, just send the patient to me. I want to evaluate the patient. So I just evaluated the patient, and this was a glaring picture on at me. The patient had just on first day, probably 24 hours after surgery, had grade 1 DLK, diffuse lamellar keratitis. This was very scary because I do not know where did this come from. So I said, okay, let's just change from fluorometholone, and I was prescribing. Now the key point here was the patient was on sodium hyaluronate. Now we know the origin of sodium hyaluronate. It is of, it has got an antigenic property. So I decided to change the lubricant, and I also started the patient on prednisolone acetate hourly. I was contemplating if I should start oral steroids or not. I just said, just come back and we'll see probably. So the patient still came to me after day 3, and he was very, very angry. I continued the CMC and the prednisolone acetate. And in post-op day 10, patient was 6.6, very happy, and said, "De raha hai, durust hai, but I can see very nicely now." But the question was that, why did the patient develop DLK? I mean, what was wrong at my end that the patient developed DLK? So here is where we are decoding dilemmas. I had operated 4 patients on the same day. Now I went back in looking at the preoperatively as the intraoperative change things that I have done in that particular patient that must have caused that inflammatory cycle to start in. So the 4 patients that underwent, only one of them DLK. There were 2 patients on that particular subset of patients who had severe dry eye disease. Now, I had mibography of both of them previously. This was the girl. If you see, there are just 2 active moving glands here for this girl. As opposed to this gentleman who developed DLK, he had fairly decent glands. I mean, of course, they looked very tortuous. But if you look at the lipid layer thickness, that was 43 and 45. That means his glands were not optimally functioning, even though he had good glands, as opposed to the girl. But what was very important here is, just because I had seen those 2 glands for that girl, I said, "Nahi, aapko dry eye hai, we have to start you on dry eye treatment," because she was also slightly symptomatic. So we started her on hot fomentation, and she was on osmoprotective eye drops because there was surface inflammation. Well, not typically surface inflammation, but I had seen slight tearfilm debris in that particular girl, so I started her on Restasis. And she was on Restasis for 2 months. Initially, she had a short bolus of soft surface steroids, and then we had continued this treatment for a longer time. But this gentleman, although he had lower lipid layer thickness, but I did not subject the patient to any treatment and was directly taken up for surgery. Now, what I want to highlight here is that dry eye disease is a fairly common component. I mean, from every specialty sitting here, every person is prescribing lubricant. That means it is not restricted to glaucoma or retina. It is a disease that every one of us is treating. I did a very small study at my clinic where if me and my father together, if we saw 80 patients in a day, 52 of them had symptoms of dry eye disease. Even if they came with their specific treatments, they had symptoms of dry eye disease. So what are we trying to say is that dry eye disease is very multifactorial now. I mean, so much so that it takes 43 words to define dry eye disease. It is as big as a short note. And how are we treating this is by lubricants. Now, this is something that my mentor had taught me. Professor Rohit Shetty taught me that when you're prescribing lubricants, it is basically if you have a displaced fracture, you are just putting a malam. The patient actually needs intervention, needs surgery, needs alignment. What you are doing, what malam is basically just putting a lubricant on the surface. We are not being mindful of what lubricant we are putting on the surface. So our treatment has to be very, very mindful or thoughtful of what we are putting on the surface. Here is one more perspective. This patient was referred to me. This was the pre-op, immediate post-op, post-LASIK topography, and after 3 months, the referring colleague told me that a patient has developed post-LASIK ectasia. I'm sending to you, cross-linking has to be done. Please send the patient back to me and I'll manage after that. I said, sure, just send the patient. Let's have a look. In 3 months, why did the patient develop post-LASIK ectasia? If you look at the keratometry, also there's significant change in the keratometry. 3 diopters of astigmatism has been induced. So I was quite certain, looking at the surface, that it is post-LASIK ectasia. But I examined the patient clinically. This patient on elevation map did not have post-LASIK ectasia, but had severe staining in the lower interpalpebral fissure. This significantly highlights of the impact our keratometric findings can have just by dry eye disease, and that is also very, very localized here. So the take-home point from this post-LASIK patient was that the patient did not have post-LASIK ectasia. The patient had dry eye disease, which was masquerading on a placido imaging as post-LASIK ectasia. So what are we trying to essentially highlight by this is that the definition of dry eye disease is multifactorial now. But what is the crux of it? Going back to our old age classification, we used to classify it as aqueous deficient or evaporative, which still holds true. But if you look at this, aqueous deficient is concentrating the tears. Evaporative is causing denaturation of proteins. That is also again going to increase the hyperosmolarity. This leads to subclinical inflammation. Now if you look at the factors, I think we have seen this slide over and over again. But this is really the truth of dry eye disease. Now look at all these factors. Very specifically speaking of post-LASIK or refractive induced dry eye disease, this is the flow chart that we see as to what is the pathophysiology behind dry eye disease in post-LASIK. Now because of there is decreased corneal sensitivity because of the denervation we cause by LASIK, this causes increased inflammation because of decreased nerve stimulation. Further, there is decreased blink rate because of the decreased nerve stimulation, causing hyperosmolarity and decrease in tear secretion. Furthermore, it causes damage on the ocular surface, causing programmed cell death, further leading to dry eye-like symptoms. Now, this may not be very classically clinically seen, but this is happening subclinically. Why does this get masqueraded? Is because most of our patients are on post-operative steroids and tear substitutes. But what would have been very, very mindful is the choice of lubricants that we use here. It is very simple, but there are very specific drug targets that are needed for treating dry eye disease. If there is inflammation or hyperosmolarity, osmoprotectants have to be used. And if there is classical clinical inflammation, we have to use anti-inflammatory in the form of cyclosporin or lifitegrast. We're still waiting on it. So to summarize all of it, my post-op prescription has changed significantly. If I see dry eye symptoms and higher OSDI, I directly start the patient on dry eye treatment. Most of it includes osmoprotective tear substitutes. Furthermore, I also start the patient on Restasis. Why Restasis specifically? It's not because it's because of allergan. Very specifically, we have looked at other forms of cyclosporin. We have used this on cell lines, and I have personally seen how the cells are very happy if you use Restasis and as compared to any other medication. And so are the patients very happy. Now here is just a passing remark. This was a randomized controlled trial, non-sponsored, where they used CMC in terms of Optiv as opposed to sodium hyaluronate, and they found that CMC reduced the surface staining significantly, as an Optiv reduced the surface staining significantly as opposed to other medications that were used. So what I'm essentially trying to say by all of it is that we need to treat surface inflammation. If it's visible or it's not, we have to look for it. And most importantly, we have to be very mindful of the lubricants that we use on the surface. It's just not the last MR that visited, but probably our logic that dictates our treatment, especially in post-refractive cases. Thank you very much. I'll be happy to take any questions if there are.
Thanks, Natasha. Thank you very much. Very interesting cases, both, of course, related to refractive surgery. I'd request Dr. Paras to give us her inputs.
Yeah, in fact, Natasha, very nice cases. And especially what I was referring to was the differential staining one should, So there are very basic, clinical examinations which one should never miss, either pre-operatively or post-operatively, before deciding or jumping onto any diagnosis. That is, jumping on, post-LASIK keratoectasia. She did the staining, and that gave a very clear idea that, patient was not having the other pathology, but patient was basically primarily having the dry eye. So it's very important to screen when you are screening your, refractive surgery patients, to screen them very well and make sure that they don't have any surface problems like dry eye. And if at all it is there, it is important primarily to treat that first and then consider taking them for the surgery so that you don't end up into, post-operative surprises in these cases. Dr. Rishi, would you like to add something to that?
No, I think I'm going to request my retina colleagues to come over, and Dr. Obuli is here. He can set up his slides while we conclude the cornea part of this session. So yeah, I think they've highlighted the point that dry eye is a very important coexisting factor in patients undergoing refractive procedures. Many of these patients are on contact lenses, and they are the ones who will generally have far more ocular surface disturbance and instability. Screen times haven't helped. They have led to a decrease in blink rates and so on. So you must screen these patients for a dry eye disease. Natasha mentioned about this patient who had severe dry eye. If it had been severe dry eye, Natasha, you probably would not have taken her up for, it was probably a moderate, which you were able to convert to a much better ocular surface. Yes. So that's why I started her on treatment before surgery. Yes, and I think Paras highlighted that fact as well, that these patients must be pre-treated for their dry eye, because you're not going to help the dry eye, you're going to make it worse, that's for sure. So 2 months of pre-treatment is what you gave her, and I think that made a big difference to her outcomes. It makes the refractive surgery more stable, it is less regression, they need less medication, and so on. And so I think that pretty much concludes the cornea part. Thank you so much, Natasha. Thank you, Paras, and Dr. Monica as well. And so we're going to go on to the retina, and we'll request Dr. Obuli to tell us about his case.
Hello, good afternoon everyone. So my topic today is decoding dilemmas in retina. So this will be a case-based presentation. This is a disclaimer. So I will be talking about 3 main topics. One is the management of diabetic macular edema, one is the VMT, one is the CSR, and fourth is choosing the injections. So first is diabetic macular edema management. So the first case is a 45-year-old male, and he came with the complaints of right eye blurring of vision, and his best eye, right eye BCVA was 6.6, left eye was 6.9, and he had both early moderate NPDR changes, and his left eye had in fact a clinically significant macular edema. Even though the patient came for a blurring of vision in right eye, it was the left eye. When we evaluated, he had a drop in the vision. So the most important thing to note here is that the patient is having a poor systemic control with a recent HbA1c of 10.8, and the FBS and PPBS the day before the examination, he had done it outside, was 140 milligram and 260. So this is the OCT. As you can see, this looks like a classic case of diabetic macular edema, and being a retina person with a trigger happy finger, everyone's first choice might be to inject immediately. But okay, then I thought actually protocol V in a way actually changed the way in which I look at patients and I treat. So I was in a dilemma, because this is the first time he's coming to the ophthalmologist with the blurring, and the blurring was also recent onset. So I was thinking whether to observe or to inject. Then I went back and looked at his systemic control, and as you can see, his HbA1c was very high, it was 10.8, and the FBS and PPBS showed that he had a pretty poor systemic control. So I told the patient that okay, so we will keep you. You first go back and you control your systemic parameters well. And I gave him a topical NSAID. And this is his 6 weeks OCT. You can see that the edema is almost gone. It's as good as any intravitreal injection. His BCVA is 6.6. So what does protocol V say? The protocol V says that, in case of similar visual acuity, if the patient is better than 6/9, and if the patient is a recent onset, a poorly controlled patient, observing or injecting aflibercept gives the same comparable outcome. So that's how I nowadays treat the patients. I always, whenever the patient comes to me first, I never go directly for the injection. I ask them to first get the systemic thing, and I talk to the diabetologist sometimes. I get an idea as to how the patient is managing his diabetes before I think about whether we should inject or not. So So then the second case is vitreomacular traction. So this is a 65-year-old gentleman who presented to me with complaints of difficulty in reading newspaper and feeling that the letters were bending. So on his examination, his right eye best corrected visual acuity was 69 parts and his left eye was 6.6. The patient was pseudophakic in both the eyes, and on the OCT in the right eye, we can see that there is a vitreomacular traction with an evolving or impending macular hole. So as you know, being a trigger happy retina surgeon, we would always think, okay, fine, if we leave it like this, it is definitely going to progress. The macular hole is definitely going to worsen. But I was like, this is the patient was also a little hesitant about surgery. He was like, okay, he was asking me a lot of questions about what is the what else can be done, can we wait for some time, and I was like, okay, I was in two minds what to do further. So I was like, okay, fine. I told him we will wait for some time, we will see, because this is the first time you are seeing. I told him that the problem of your bending letters and difficulty in reading newspaper, you have to bear with it for some time. If you are willing to bear, then we will give it a chance to for natural history, and we will see. So I gave him some topical NSAIDs and I asked him to come back after a month. So this was the right eye OCT after a month. You can see that the PVDs right now has totally induced, and there is still some subfoveal neurosensory detachment there. The patient was 6.6 parts, but he was saying actually that he was able to read the newspaper a little better, that bendy, wavy nature of the thing is actually not there right now. So that's after, this is after 3 months, and you can see that the contour of the fovea is actually as good as normal. So coming to the gas classification of VMT, we see that there is 0, 1, 2, 3, 4 depending on that, and this was a case of type 1. And so now coming to the natural history. There was a recent meta-analysis of VMTs, and they said that 32% of vitreomacular traction, they resolve spontaneously without even the doctor doing anything. So this is the protocol of management. Whenever you have a case of vitreomacular traction, you see whether the patient is symptomatic or asymptomatic. If the patient is asymptomatic, better to observe rather than to touch. If the patient is symptomatic, then you see what can be done. The first thing you have to do is observe. You have to wait for the PVD to spontaneously induce if it is an incomplete PVD patient, and then you keep reassuring the patient. And if after some time the VMT is still not resolving, then you can go for either ochriplasmin, which in India it's still sparingly used, it's not that very well used. And if at all, if after ochriplasmin, or if sometimes you don't have the need for, have the facility of ochriplasmin, you can directly go in for a surgery to remove the vitreomacular, relieve the vitreomacular traction. So what I want to say with this is that you shouldn't be trigger happy that much. You can just give it a chance for the natural history to take its course, and even after that it doesn't happen, then there is always a surgery to fall back to. Because the first time we see some patient and we immediately advise any surgery, the patient is also a little taken aback, because the patient is not mentally prepared. So giving it a time, giving the natural history to happen, the patient will also be a little bit more, convinced about what you say, and then he will listen to your advice. So the third case is, this is coming to CSR. So the 30-year-old IT professional came to me with sudden onset black spot in the center of the vision for the past week, and in the right eye the best corrected visual acuity was 680 and in the left eye was 6.6. The right eye fundus showed a serious detachment of the posterior pole involving macula, and left eye fundus was normal. So this is a OCT of right eye and presentation. It looks pretty dramatic, but it is a fresh case of CSR, and there is some fibrin, and then there is a neurosensory detachment over the papillomacular bundle. There is a PD over the papillomacular bundle. So I was, now coming to my way, so I always first talk to the patient. I always talk to the patient. I ask them what they do, how they are. I try to evaluate how the patient is as a person, what kind of stress he is undergoing. And so this is my most 5 common things I evaluate in a patient, whether the patient is a type A personality, whether he's irritable, whether is a person who is getting angry all the time. That you can see actually in the OPD. When the patient is not able to wait for some time, he keeps on coming, barging in and again. So that itself gets me an idea whether the patient is a type A personality. Then if there is any persistent insomnia or lack of sleep, persistent stress in his workplace or emotional turmoil, extreme use of alcohol or smoking, and people won't say unless you probe a lot about alcohol and smoking, and the use of steroids. Actually, post-COVID, anyone who you ask, they would have taken a course of steroid, or sometimes young ladies who come with steroid creams for fairness creams and whatnot. So you have to talk to the patient and understand his condition. So coming back to my patient, I was talking to him for 15 minutes, and you could see nowadays post-lockdown, all the work from home, the patient was telling that I was not able to meet my targets, I am not able to sleep well, and that gave me an idea as to where the problem lies with the patient. So I counseled the patient about the lifestyle modification. I told him the need for sleep, reduction of stress. So I gave him just an anxiolytic and topical NSAID, and after a month the patient is actually completely resolved. He came back, he thanked me, he said he had reduced his work hours. So whatever, so you have to talk to your patient. There is no need to be trigger happy to directly go in for a fluorescent angiography or try to go in for a laser. Most of the time the fault you can identify by talking to the patient and identifying what he's going through, and then treating it subsequently. So this is a management protocol for persistent CSR. So in case of persistent CSR, after repeated FFA, you see some kind of a diffuse leak or something, and you are not able to laser it off, you can always go for a PDT, although it is not available in India that frequently nowadays. And then there is always the other treatment modalities, which include micropulse laser, which is also pretty effective. Or then sometimes you can start him on eplerenone or any mineralocorticoid receptor antagonist. These are all the other modalities I frequently use in my chronic CSR patients. So those are the three talks. Thank you.
Thank you, Dr. Ubali, and I'm going to request Dr. Shrutika to come up, set up her slides while we request Dr. Vasumati to give us her comments. So thank you for those three cases. I think you're terrible for the industry. You didn't do anything for any of the three, and you actually observed them all, and they all got better. So great credit to you as well. So Vasumati, your comments, please.
Thank you, Dr. Ubali, for those nice cases. And so the first take-home message, I think, from Dr. Ubali's cases is that retina specialists are not trigger-happy, and actually they are judicious people. So thank you for pointing that out to the anterior segment colleagues. So we'll just take each case at a time. The first was a diabetic macular edema patient who, I mean, you're very lucky considering that within just 6 weeks, both the subretinal fluid and the cystoid macular edema became all right with just masterly observation. The hemoglobin A1C was 10.8. By any chance, did the hemoglobin A1C become all right in 6 weeks? Okay. Okay. So personally, I would think a sudden and dramatic reduction of hemoglobin A1C is not a good thing to happen, because that can paradoxically worsen the macular edema. So we should always make sure that there's a gentle reduction in the hemoglobin A1C. In fact, 10.9 to 8.1 in 6 weeks itself is too steep a decline. So that is not advisable. You are lucky that your patient went well, but the take-home message is look at the systemic status of the patient. Not all edemas need to be injected or treated. Fair enough. I would just like to differ regarding the protocol V. Now, before we bring in extrapolate findings of randomized clinical trials into our practice, we have to see the patient as a whole. In fact, in diabetic patients, each eye behaves differently from the other, even in the same individual, as you're aware. Now, protocol V, of course, told that, in eyes with very good visual acuity, say 20/25 or better, we can observe the patient. But if you read protocol V carefully, in a subgroup analysis, it definitely said that 77% of patients who underwent anti-VEGF, I'm not naming the anti-VEGF, though everybody knows, did actually better than observation. And there's another caveat. Patients who were on laser or observation, if they didn't do well, they received anti-VEGF. So it just beats the same purpose of the study. So protocol V is definitely a good study to quote, but we cannot blindly follow that study in clinical practice. And in resistant cases, especially in pseudophakic or patients who are going to have cataract surgery, intravitreal steroids also play a very important role, and especially combination treatment, as a rescue therapy along with anti-VEGF agents, as shown beautifully in protocol U. So the take-home message from the first study is look at this patient systemically as a whole. And diabetic retinopathy is a holistic disease, so you always look at the big picture, point taken, but don't extrapolate the clinical studies blindly into clinical practice. Use your judicious judgment. So thank you so much for that nice case. The second case of vitreomacular traction, also the natural history of 32% resolution of all VMT cases is well known in literature, and your patient was lucky in that it happened in him. That's the main reason the world has given up on ochriplasmin, because it just doesn't work, because the natural history itself is the same, 30%. So it didn't have anything additional to offer. So, but I would be trigger happy vitreous surgeon in that case. Your case, 60% of the time definitely progresses, the macular hole progresses and there's more distortion. And we all know that before the photoreceptors undergo damage, it's better to operate, and the hole closure rate is excellent when the dimensions of the hole are pretty small. So you keep the patient under follow-up. I would have personally followed up the patient every week. I had an emeritus professor from IIT who presented exactly like this, but within 2 days he deteriorated. So it's always better to follow up the patients within a week, repeat the OCT, and if there is ongoing traction, tell the patient and he will be more than happy to undergo the surgery in your hands. So thank you for that case. And the last case, CSR, of course, like all of us know that, many CSR patients, even today, we see being treated by steroids. So the take-home message that I would say is, just make sure that your patient is not on, or CSR patient is not on steroids of any kind, as beautifully pointed out by Dr. Obali. Another thing is alternate therapies. In South India especially, it's very common that patients have received either Ayurveda or Siddha from not so qualified practitioners, which all have a liberal dose of steroids and heavy metals. So do ask the patient about history of alternative therapy, and in very bad cases, rule out endogenous hypercortisolism as well. So that's also another thing which you have to rule out. If your endogenous cortisol levels are very high, then no amount of counseling is going to work for you. You have to work in concert with an endocrinologist. So thank you so much.
Lovely. Excellent. I think that was beautiful, and I think
thank you.
Kudos for those discussions. So I think the points are well taken. With the first case in DME, yes, I think close observation. And I think the compliance, and that is something that the clinician has to read, whether this patient will come back for follow-up, or is he just going to get lost and then come back with complications later on. I suppose the same is true for VMT as well. For someone like me who's more anterior segment, would something like a Amsler grid help these VMT patients for their self-monitoring, or is it overrated kind
of thing? Amsler grid is I feel it's more overrated only. Of course, it's a good tool to tell the patient. In fact, even a high contrast ETDRS chart, for instance, doesn't really tell us anything about the quality of the vision. If you ask the patient how comfortable he is in a low contrast situation at night, say even the DME case which Dr. Obali presented, so I'm sure they will have a lot of problems. So, and most of the studies just talk about distance vision. They don't even talk about near vision. And Amsler is only, at least in my hands, in my practice, we do, every patient goes back with an Amsler chart. Every macular patient goes back with the instructions. But I have not seen any good positive feedback or the patient coming immediately based on the Amsler, when the differences in Amsler. So it's probably overrated. That's what I would like to say.
Thanks very much, Dr. Shrutika.
Yes, good evening, respected panelists and dear delegates. So I'll be talking about multifocal eye implantations and retinal comorbidities. As comprehensive ophthalmologist, all of you must be doing cataract surgeries with multifocal IOLs more and more commonly these days, with the array of multifocal IOLs more and more available than earlier. So I will start. I have no disclaimers to make, and I would start with a case where a 70-year-old female cardiologist presented to me, and she was completely devastated after her new vision following a multifocal eye implantation which was done elsewhere, and she had come to us for a second opinion. And ironically, this patient was pretty happy preoperatively with contact lens assisted monovision, where she narrated that she was used to contact lenses, one for distance corrected and the other eye was corrected for near. But the only reason why she was tempted to undergo a cataract surgery was to get rid of the contact lenses, and hoping with multifocal eye implantation she would be able to see distance and near very clearly without the need of wearing daily contact lenses. But unfortunately, The vision, the uncorrected vision in the right eye when we examined her was 612 N10, and in the left eye was 618 N10. Even after best spectacle correction, the vision improved to, quantitatively it increased to 69 N6, but she wasn't very happy with the quality of vision. So there she landed in a lose-lose situation where she neither got rid of contact lenses or spectacles, and nor was she happy with the quality of vision. So when we looked into her retina, as you see, the retina appear normal except for few RP alterations that you see here, and you see the fovea appears dull. So this may not be very evident in a setting of cataract where the view is very hazy, but OCT can come to rescue here. We did autofluorescence fundus photography, and you see this RP cell loss in the foveal area and the parafoveal area, which was also translated seen in OCT, where you see the ISOS junction doesn't appear very healthy and mildly disorganized in both the eyes. So here we knew why she was unhappy. An unhealthy macula and MFR leads to compounded reduction of contrast sensitivity and dissatisfactory vision outcome. So both the things, the retina and the multifocal IOL, was contributing to lack of contrast sensitivity and a poor quality of vision here. So the lesson learned here was patient was not very symptomatic, hence the cataract surgery could have been delayed. An IOL choice considering preoperative vision adaptation is very necessary. Patient was well adapted to monovision, and hence a monofocal IOL implantation aiming at monovision would have been a wise decision in this case. So now I'm going to discuss a few retinal conditions which can be missed easily, and how OCT and autofluorescence fundus picture can come into aid here. So when we are considering multifocal IOL, we should ask one question: am I missing something in retina? A seemingly normal appearing macula may have some functional and structural pathology which can be missed. So here are a few macular lesions that can be missed. So an early epiretinal membrane or a cellophane membrane would appear very normal, especially in a setting of cataract. But there could be a loss of foveal dip on the macular osity as seen here. And the other clues that we can have on funduscopy is abnormal glistening reflex from the inner retinal layer and a misdirection of central macular vessels. These are the clues to figure out a cellophane membrane or epiretinal membrane. A very early vitreomacular traction, as Dr. Obili also showed, can be missed easily in the setting of cataract, as seen here, and also a macular hole, which is very tiny, can be missed, but which can be easily picked up on the OCT. Drusins would appear like few yellow spots in the macular area, and the OCT would show a mildly bumpy RP cell line here, and very early RP changes may not be very evident on funduscopy, but there could be just retinal or foveal thinning that you see here, and mild disorganization of the external nerve fiber layer. Idiopathic macular telangiectasia again would be just seen as mild perifoveal whitening, along with some thinning in the OCT and some retinal cellular defects, which could be very, very minute. A resolving central serous retinopathy again can be missed. As you see here, the fundus may appear pretty normal, but there is a small gap here in the subretinal space, which could indicate it could be an old CSR which is now resolving. So macular lesion that can be missed can be as gross as CME also, because just an inflammatory CME would have no other retinopathy changes and may appear normal until we do an OCT and see CME, and this can be very easily treated preoperatively or during the cataract surgery with an intravitreal implant of steroid. So to conclude, A meticulous checkup along with preoperative OCT macula, autofluorescent fundus photo, corneal topography should become preferred practice, especially when considering multifocal IOL. A preoperative macular spectral domain optical coherence tomography in patients where we consider advanced technology intraocular lenses for cataract surgery is become very mandatory, because these patients have very high expectations because they know they are getting a very expensive implant into their eyes, and it's imperative that all these patients undergo OCT and topography as a preoperative workup. Thank you.
Thanks, Dr. Shrutika. I think you highlighted that case beautifully, and I'm going to ask Dr. Basumati to give us her comments.
Thank you, Dr. Shrutika. Lovely cases and lovely pictures. And the take-home message, I think, is very obvious. As the expectation of the patients become higher and higher, as the prices of the intraocular lenses also, especially the multifocal and the higher order aberration-free lenses, as the prices increase, so does the expectation of the patients as well. So it's very important that even general ophthalmologists doing cataract surgeries, routinely use a high quality optical coherence tomography. A time domain may not be able to pick up everything. A high quality spectral domain OCT becomes almost mandatory in such patients, especially if the media is hazy and you're not able to see the macula. And also, if the fovea can be seen, an indirect ophthalmoscopy doesn't give that much, you cannot make out all those finer details that well. A good slit lamp biomicroscopy with a 78D or a 90D lens, the importance cannot be, overemphasized. So we have to be astute clinicians first. Never hesitate to order the OCT. You are not overdiagnosing. You're not doing anything extra to the patient. You explain that you're not able to see the fovea clearly. You want to rule out certain age-related changes. This is especially true in the case of diabetics, because 1 out of 5 patients who walk into our clinics is a diabetic, and the incidence of parafoveal telangiectasia, PFT, so beautifully brought out in your last case, is so high in diabetic patients. So they may not have diabetic retinopathy, but they may be having PFT. And the gold standard for diagnosing PFT is optical coherence tomography. And also a good look at the outer retina. All of us tend to, see the inner retina, because that's the more beautiful aspect. But it's like anterior segment surgery versus posterior segment surgery. But it's important that you look at the outer retina also in OCT, especially the integrity of the external limiting membrane, more than the ISOS junction. In your first case, if you would see, the ELM was not seen at all. So the ELM integrity is so important because it helps us to prognosticate also to the patient. A partially healthy or a partially unhealthy ELM is a good prognostic factor when compared to a completely unhealthy or absent ELM. So do look at the epiretinal membrane, and regarding the external limiting membrane. And regarding the other membrane, epiretinal membrane, it's very important that before you operate, the case that Dr. Shrutika showed, the epiretinal membrane was not causing any distortion of the foveola, but there was a flattening of the fovea and a moth-eaten appearance of the perifoveal architecture. So such cases, do not hesitate to start the patient on preoperative non-steroidal anti-inflammatory drops and continue the drops for 3 months post-surgery, because these patients have a very high incidence of Irwin gas syndrome. Any diabetic, you have to start the patient prophylactically on topical NSAIDs, more so if the diabetic patient happens to have an epiretinal membrane like this, even if it is not causing any distortion of the foveolar architecture. So be strong on pre-op NSAIDs. And drusense, usually, especially the picture that you showed, they shouldn't be a contraindication to a good multifocal IOL, but it's important to stress to the patient that he has an incidence of increased risk of, say, a geographic atrophy or a wet AMD, and put him on antioxidants which follow the AREDS2 formula, so that whenever you're very frank and explain everything to the patient, you have the patient's confidence with you, and he is a patient for you for life. So I think that's about it. Thank you very much for those nice cases.
Thank you.
Very nicely put again, and thank you, Shrutika, and thank you, Dr. Vasumati. So, very quickly, I think the patient that Dr. Shrutika brought up was a multifocal IOL. So actually, there's a bit of a synergy here with the anterior segment people. So, Paras, would you have a comment? This patient had already had bilateral surgeries. And my question firstly would be, if you are unhappy with the first, why would you even do the second? And so if there's a first patient which has come with a 618 distance and an N10, there's obviously something going on which would forewarn you. So, you know, the concept of doing a simultaneous bilateral, or the concept of doing, especially with premium IOLs, to do them back to back, I personally wait at least a couple of weeks. She wanted to get them on consecutive days. So I see, okay.
Yeah. Yes.
Yeah.
Multifocals you have to.
And I think equally important is to look at the anterior segment. And I recall going back about 10 or 12 years, I missed an epithelial basement membrane dystrophy. And that patient was so unhappy because the best corrected vision that she got with the multifocal was 618 and 10, and just like your patient here. And she actually deferred, and she was kind enough to come back for the other eye where I put in a monofocal, and she's much happier with it. So there is an equal importance to any refractive layer, and the anterior cornea is as important as the macula, I guess. In diabetics, in patients with drusen, for me these are orange flags at least, if not red, for multifocals. I'm very, you know, sort of on the backbench as far as multifocal implants are concerned, because they are demanding lenses and they need perfection in many ways. Paras, any comment on this?
Yeah, in fact, both the cases, you know, I mean, were fabulous cases, and I would say that again, you know, I mean, to summarize it in one line, there is no shortcut to thorough clinical examination before venturing into such higher end, you know, I mean, lenses. Like, you know, the post-cataract surgery, the patient would be very unhappy, and even the surgeon would be very unhappy with the outcome. So again, it goes back to the basics that, you know, I mean, there is no shortcut to a thorough examination, clinical examination, and then only select these patients. Thank you.
I have a question. So there is this, theory of doing OCT in every patient wanting to undergo cataract surgery. So camp A says you are making money, camp B says if you don't do, you are going to miss out some critical rare findings. So which camp do people belong to, majority?
I think what's happening now, it's becoming a standard of care gradually for premium IOLs. So I think it will eventually translate to every IOL, I guess. So no, there are now legalities to it as well. You see, that's the other thing. So sometimes you have to do defensive medicine just on the fact that you're going to be hauled up by somebody for some reason. And so and that's what's happening, and that's probably the trend everywhere. The thing with the penetration of devices like the OCT going out now into even the smaller clinics, which is a good thing, means that at least you have access, the price will come down, and
OCT is in fact commoner than fleas. In almost every clinic.
yeah.
So I think it's very important. And the most important thing is, as Dr. Rishi Mohan said, you know, and Dr. Paras said, is a good clinical examination. There's no substitute to clinical examination, and also documentation of all your findings, discussion with the patient, and a good surgical consent. I mean, explaining everything. For example, even in a macular hole, we explain that, you know, even after the hole closes, it can reopen 2 to 3 years later. So explain everything, what can happen to the patient, get a good surgical consent in the patient's own handwriting, especially if the patient is going, you know, for a high profile IOL. I think there's no substitute to that, but to be on the safe side, we can offer the patient the option of getting a good quality OCT done, just to make sure you're not missing anything. I think we are justified.
So I think I must thank my panelists, all the speakers, and Allergan for constructing this session. Greatly enjoyed moderating it as well, and learned a lot as well from my colleagues. So thanks very much, and hopefully we'll see you soon. So thank you very much.
Thank you, Dr. Rishi.
All the speakers had an excellent presentation of cases. So it was a very good mutual learning.